Hi, my name's Hayley. My daughter Jessica over there has had ME for 11 years, so I know a little bit about the struggles of people with ME. I work as a midwife in the NHS. Whilst at university, my undergraduate major project was a literature review into ME and pregnancy. However, once I got started, I realised there wasn't any literature to actually review. I'd set myself quite a tricky task. It highlights the desperate need for research in this area. It's a chronic, disabling, multi-system disease. It's estimated that approximately 250,000 people in the UK have ME and 17 million worldwide, although it's further estimated that 90% of cases are undiagnosed, so this figure is much higher. 76% of ME sufferers are females of childbearing age, with a peak age of onset being 20 to 40 years. ME affects women's health, impacts on fertility and plays a part in many gynecological conditions. People with ME experience debilitating pain, post-exertional malaise and a wide range of fluctuating symptoms which differ from person to person. There's no diagnostic test for ME, rather a diagnosis is reached by considering the symptoms and by a process of elimination. This can make it difficult to manage from a medical point of view. ME is unpredictable and symptoms change over time. Orthostatic intolerance and postural orthostatic tachycardia syndrome, so POTS, are conditions of the autonomic nervous system and are hallmark symptoms of ME. These conditions are characterised by tachycardia, episodes of fainting, nausea, cognitive dysfunction, exercise intolerance and fatigue. Furthermore, one study found that a small left ventricle with reduced cardiac function is common in ME patients. Low blood volume is commonly found in people with ME, and fibromyalgia is a common comorbidity. The World Health Organization lists ME as a disorder of the central nervous system under post-viral fatigue syndrome. NICE described the physical symptoms of ME as debilitating as multiple sclerosis, systemic lupus erythematosus, rheumatoid arthritis and congestive heart failure, and other chronic conditions. POTS is an abnormal increase in the heart rate that occurs after sitting up or standing. Symptoms including dizziness, fainting. Some people with ME experience cardiac arrhythmias, tachycardia and or palpitations. So why is it important to consider ME during pregnancy and throughout the childbirth continuum? During pregnancy, a number of cardiovascular adaptations occur. There's an increase in cardiac output, an increase in blood volume of up to 50%, a decrease in blood pressure caused by vasodilation, which is a widening of the blood vessels. Blood flow to various organs is increased to meet the increased metabolic needs of tissues, and therefore venous return and cardiac output increases. So 30% of women with ME report an improvement in symptoms during pregnancy. This could be due to the increased blood volume in a previously poorly perfused woman. However, it's my concern that if a woman's cardiovascular system is working at capacity and she then gets pregnant, her body must then deal with the increased burden on the cardiovascular system, and it could be an accident waiting to happen. Hyperemesis gravidarum, or severe morning sickness, is a problem common in early pregnancy. There's some evidence to suggest this is caused by the adrenal cortex being unable to meet the increased demands for cortisol in early pregnancy. In response to this, the adrenal cortex grows. This usually occurs toward the end of the first trimester, at which point the nausea and vomiting will cease. If supply does not meet the demands, the nausea will continue. In addition to this, cortisol is a stress hormone involved in the regulating the immune system, carbohydrate metabolism, controlling the blood pressure, and in pregnancy supporting the developing fetus. In early pregnancy, increased cortisol producing hormones suppress the immune system to prevent it from rejecting the developing fetus, and later regulate blood flow between the fetus and the placenta. Estimated levels of maternal cortisol in late gestation is associated with accelerated development in their first years of life. There is evidence which suggests that the majority of women with ME have clinically significant adrenocortical dysfunction. This means that these women may have an increased likelihood of developing hyperemesis gravidarum, and for it to continue throughout pregnancy. In addition, one study found that developmental delays or learning difficulties have been reported twice as often in children of women with ME, although further larger scale studies are required to confirm this. During labour, it's important to remember that fibromyalgia is a common comorbidity, which is characterised by musculoskeletal pain and soft tissue sensitivity, hyperalgesia, which is an increased sensitivity to pain, and allodynia, which is pain due to a stimulus that does not normally provoke pain. Research has shown that energy production at cellular level is altered in ME. In healthy individuals, cells produce energy in the form of adenosine triphosphate, or ATP, using the process of cellular respiration. ME patients have been found to exhibit excessive mitochondrial respiration in muscle cells, causing the cell to switch from aerobic to anaerobic respiration, which produces increased lactate, resulting in muscle fatigue and pain. This is problematic for the labouring woman, as glucose utilisation and production are increased to cope with the demand for energy due to skeletal and uterine muscle contraction. If the cells do not have the ability to convert this glucose into energy, the woman will become exhausted very quickly, exacerbated by the potential pain sensitivity and lower pain tolerance. Epidural anaesthesia is a popular choice for pain control during labour. However, a common side effect of the epidural is a fall in blood pressure, and as a result of vasodilation. Remembering that orthostatic intolerance and POTS are common in ME, it's advisable to be extremely cautious of any procedure that will further lower the blood pressure. When considering pain relief options, it's important to consider pharmacokinetics, which can be affected by the physiological changes during pregnancy. For the woman with ME, there are further implications, as drug intolerance and side effect susceptibility are reportedly increased. Arguably, the increased blood volume in pregnancy may counteract the drug intolerance, but this is yet to be researched. Vigilance and regular observations required to monitor the woman for adverse side effects is required. ME is characterised by post-exertional malaise, which is typically delayed and with a slow recovery. Minimising all types of exertion where possible and managing pain effectively may help to ease the effects of post-exertional malaise after delivery and to enable the woman to care for herself and her baby. In terms of delivery, a diagnosis of ME does not automatically indicate a delivery by caesarean section. However, one study suggests that a caesarean section in the first stage of labour will avoid maternal exhaustion and a subsequent relapse. Another recommended early caesarean section in order to avoid the physical aspects of labour and demands of labour. It's important to weigh up the physical demands of a vaginal delivery against the alternative of recovering from major surgery. Unfortunately, 50% of women experience relapse within weeks of delivery, as the stress of labour can cause dysregulation of the autonomic nervous system. The commonly used Valsalva manoeuvre, which involves a woman being asked to take a deep breath, hold that breath, and push downwards when a uterine contraction starts during the second stage of labour, can cause hemodynamic fluctuations which may exacerbate the POTS symptoms. For those women who opt for a vaginal birth, the limited literature available suggests that assisted delivery using forceps is inevitable. This is also recommended in cases of women with cardiac disease, where the Valsalva manoeuvre is contraindicated. It's also an important point for consideration, as the delivery assisted by forceps is not without risk, such as the risk of 3rd or 4th degree tears, incontinence and thromboembolism. All that I've spoken about today is based on a small number of studies, as there's been very little research into ME and pregnancy. Existing studies include small cohorts, so more research with larger cohorts is desperately needed. So today I'm asking for more funding into ME and pregnancy, and this should include how pregnancy affects ME, because by developing a greater understanding of how pregnancy affects this multi-system disease, we can explore how to treat women, either to prevent adverse health outcomes or to look to improve the general health of the individual. The research should include looking at increased blood volume during pregnancy, hyperemesis and ME, exploring the cortisol levels in the ME and population in general, and monitoring further the effects it has on hyperemesis gravidarum, including which treatments or combinations of treatments are most effective so that a plan of care can be developed for these women. Low cortisol and developmental delays. Extending on from the previous recommendation, research is required into low cortisol levels and the impact, if any, this has on developmental delay in children. Cardiac function in pregnant women with ME. Explore cardiac function in women with ME and the changes which may occur during pregnancy. And the effect of pain relief during labour on potential hemodynamic instability in ME, particularly looking at how epidural anaesthesia can minimise instability. So finally, I was reading on the ME Association's website and they have some new research coming out. So they're starting a pilot study in July 2023 into ME and pregnancy. It's a small study which aims to look at the research priorities of people with ME and how pregnant women are looked after during pregnancy with ME. As a midwife, I can tell you that they're not. The pilot study has been granted 30,000. This is a wonderful first step, but there's so much more to do.